Hi, I am Anu Agarwal and I am an affiliated faculty at the Philip R. Lee Institute of Health Policy Studies and an assistant professor in medicine at UCSF within the Division of Cardiology. Clinically, I am an adult congenital heart disease, which I will refer to ACHD going forward. I'm an ACHD cardiologist and also specialize in managing women with complex cardiac conditions throughout their childbearing age. I'm also director of ACHD research in the Division of Cardiology, and my research primarily involves around understanding healthcare needs of the ACHD patients and identifying ways to improve their healthcare access and support patients in maintaining lifelong care. While going through my adult cardiology fellowship training, I found myself often using evidence based treatment for many adult cardiology patients, such as those with heart attack. This is because of the vast number of randomized trials that are available to help guide us. In contrast, during my ACHD rotation, I was struck by the lack of available epidemiological data and evidence to appropriately manage ACHD patients. This is where I saw an opportunity to build evidence for managing these patients, and it got me really interested in this field. Thanks to the advances in pediatric and surgical care, that we have a tsunami of these adult CHD patients over the last few decades. Currently, there are estimated more than 1.5 million of ACHD patients living in the US, and their numbers are increasing by 40 to 50,000 every year. However, about 85% of these patients do not maintain continuous lifelong care for their heart condition. Major gaps being at the time of their transition from the pediatric doctors to the adult healthcare systems. This results in significantly increased healthcare costs and poor outcomes in these patients. One of the major barriers that these patients experience is around insurance policies. While these patients are under their parents' insurance during childhood, they experience significant insurance related barriers during adulthood. One of the reasons is that they are less likely to be employed and have employer based sponsored insurance. Further, before Affordable Care Act, when adults with CHD tried to purchase insurance in the individual market, they faced exclusion or high premiums because of their pre existing conditions. In addition, we and other investigators have shown that uninsured ACHD patients are more likely to have emergent hospitalizations and thus higher costs of healthcare. Thus, identifying ways to improve access to lifelong care for these patients have huge practical implications for healthcare and health policy. I have realized in my work that strategies we design to improve access to care should focus primarily on addressing the challenges faced by those at the highest risk of having gaps in care. These are patients from underprivileged backgrounds, such as those living far away from ACHD specialized centers, those from diverse racial and ethnic backgrounds, and many others. Hence, my primary focus currently is in working with these specific community to understand their needs and develop solutions for them. I have been focusing lately on a lot of digital solutions that could be more applicable and can be reached to these patients even in the remote areas. This could be then tailored to other ACHD patients and also applicable to all adults with chronic childhood conditions. Thank you.